Apologies here. That's for you can see the sun coming in here. So
That's okay. You look great, Webb. You look great. It makes
it's
you
at
more
this
even more interesting. Uh,
particular moment of the day, it's unblockable.
yeah, so we're just going to get started here. So with our guest, Dr. David Katz, and Webb and I continuing this effort to try to find real thought leaders within healthcare and within U.S. health. We thought David would be a wonderful guest to walk us through some of the different trends and some of the different questions and concerns and issues and opportunities that exist across this industry. So, David, maybe if you start by giving us an introduction to yourself and your journey and what led to you being here today.
Sure, Roy. So pleasure to be with you, gentlemen. Thanks so much for having me. There are various ways to tell the tale, but in brief, my father's a cardiologist. I was exposed to medicine, that system from an early age, and inspired by it. As I remember distinctly as a young kid, hearing my dad on the phone when he was on call and using words and terminology I didn't understand, but I could feel the gravity of it and recognize that when someone was in mortal peril, my dad was one of the people they called, and routinely he had to leave home and go to the hospital and do that at all hours and on weekends. Back in those days, he was on call every other night and every other weekend, and that went on for years. And then, in addition to my father's example, I, I was one of those boys will be boys types, and routinely in the ER myself and being put back together by orthopedists. So I had an appreciation for what the medical system did for me. So when it was time to decide what to be when I grew up, medicine topped the list, and I decided to go that route. Did not love medical school, at least not initially. I was an undergrad at Dartmouth and loved Hanover, New Hampshire. I loved the country. Went to medical school at Albert Einstein in the Bronx. That was a harsh transition, so there was culture shock involved. And for the first time in my life, I was the recipient of more information than I wanted to know. The first 2 years of medical school, they effectively saw off the top of your head, put in a funnel, and dump data and information in until you cry uncle. So that was odd for me, not wanting to know everything. And so I was a little unhappy. I thought I had perhaps made a mistake and started shopping around and came up with the idea that I was going to become a chef. I was going to finish medical school to justify my parents' investment in me, but then go to the Culinary Institute, become a chef who could address health through food, because I recognized growing up the profound importance of physical activity and diet in my own health. And that's where that story began, and wanted to pay that forward. Then I got on the ward, started taking care of people, fell in love with that part of medicine, the true part of being a doctor. It was what I had hoped it would be. Changed my mind, went on to do internal medicine after medical school. And then while doing my 3 years of internal medicine residency, I had the epiphany at some point that I was being trained to be one of the king's horses and one of the king's men. I'm a big picture person. We talk about people who can't see the forest for the trees, and that actually does prevail in academia, where there are rewards for scrutinizing the smallest parts of the smallest parts of things. I have the liability of being drawn to the whole forest. And in residency training, where you're spending 100 hours or more in the hospital every week, the big picture pattern is that overwhelmingly people have horrible stuff they never needed to get. So the people populating hospitals have heart disease they didn't have to get, and often have cancers they didn't have to get, and diabetes they certainly didn't need to get, and the complications thereof, and on it goes. Back in those days, AIDS too, which of course we knew how to prevent with behavior modification. So I thought, well, we are the king's horses, the king's men. We keep sending ambulances to the base of the wall after the fall. We do nothing about the wall. We do nothing about Humpty's balance problem. We should do balance training. There should be a seatbelt up there. There should be cushions at the base.
Maybe Humpty's drinking problem.
Maybe, exactly. And nobody's bothered to ask that question, all that. I mean, there's just got to be a way to prevent this history from repeating itself again and again and again. I don't want the next cohort to succumb to all the same avoidable maladies as this cohort. So yeah, I want to be one of the people that's called in moments of urgent need. I do want to do that. It's a rarefied privilege being a clinician. but I don't want to just do that. I've got to do something about the damn wall. So I started shopping around for that opportunity, found my way into preventive medicine, which I hadn't known existed. Lifestyle medicine did not yet exist, at least not by that name. And the rest is history. So my career was focused on the wall, if you will, taking care of people who'd fallen off the wall, yes, as an internist, but doing everything possible to modify the experience so fewer people fell in the first place. And in particular, I focused on lifestyle factors, nutrition in the vanguard, because of a single paper I read shortly after completing my second residency in preventive medicine public health. That paper was published in JAMA, Journal of the American Medical Association, in 1993 by Bill Foege and Mike McGinnis, two preeminent epidemiologists, entitled Actual Causes of Death in the United States. Bold, provocative title, but rightly so. Essentially, in that paper, they looked beyond what gets listed on death certificates as the proximal causes of death. So someone dies of cardiogenic shock, secondary to congestive heart failure, secondary to myocardial infarctions. That's usually as far as a death certificate will take you. You've got to push to ask the question, well, what caused the myocardial infarctions? You may then get the answer atherosclerosis. You've got to push even harder to find out, but what caused that? That's what McGinnis and Foege did. That's the gift they gave modern biomedical science. And they enumerated a list of 10 factors identified as the root causes of premature death. And the beauty of their list was that everything on it was modifiable by means already at our disposal back in 1993, certainly at our disposal now more than 30 years later. So the question then becomes, is that knowledge power? And what I decided was I can't justify the pursuit of rarefied knowledge we don't have in my research career, when simply turning what we already know into what we routinely do would eliminate 80% or more of premature death and chronic disease in the world around us. So that single paper altered the trajectory of my career and made me focus on leveraging lifestyle in general, nutrition in particular, to add years to life, add life to years. And I did that both clinically in my research career and in the teaching and public speaking that I've done. And worth noting before we continue the conversation that when that list of 10 factors was enumerated, the first 3 items on it alone accounted for 80% of the total. So the full list accounted for almost all the premature deaths in the country every year. So modifiable factors explain all premature deaths in the United States every year, but for a rounding error. Stuff we know how to do could prevent nearly all premature deaths. But 3 things could prevent 80% on their own. And those 3 things were tobacco use, poor diet, lack of physical activity, bad use of feet, forks, and fingers. Back in 1990, tobacco was number 1. Today, because of less smoking and further deterioration of our use of feet and forks, the number 1 predictor variable for premature death and chronic disease in the United States is nutrition quality, the overall quality of diet.
In your mind, firstly, I mean, I have so many questions to ask you, so I just have to organize my own mind.
The liability of a long rambling answer, sorry.
No, it's the liability of covering such big topics for so long and doing so much with them. There's just so many ways to approach this. And I love it. I love the challenge, but it is a challenge. So you founded the Prevention Research Center, or with a co-founder at Yale. You've authored 19 books. You have focused committedly, almost religiously on this key goal of preventative behavior. How do you, I mean, the first question I'm going to ask you is, how do you delineate between preventative behavior, preventative care / medicine, and healthcare in general? So I see in behavior maybe a connection to this word health. And I do think that the nomenclature, it's not nomenclature, it's really important definitions that lead to understanding. And my first argument in the web, feel free to just get stuck in, is that we've actually mislabeled as a public, both here and overseas. The first mistake we've made is we've mislabeled everything. We've confused the labels. because they are confusing. I see a world of difference between health and healthcare. You might as well be talking about health versus aeronautics and the aviation industry. You don't really combine those two things. One is a jug of water and the other is a loaf of bread. I think health is a jug of water and healthcare is a loaf of bread. And yet in our minds, I'm sure I'm confusing people just by saying this. Health is physical activity. Health is diet. Health is, how I go about my day. Do I get enough sleep?
Yeah,
Or
yeah.
too much stress? Healthcare is, how is my oncologist doing? Do I have quick access to a primary care physician? And do I need an MRI?
So I agree with the fundamental point, Ryan. As Webb knows, I've written expressly on this topic. I back in the day was writing for Forbes as well, and wrote a piece called "From Disease Care to Healthcare: Monetizing the Revolution," thinking about the obvious changes that are required to take what really is a disease care system to its full expression as a genuine healthcare system. And the challenge inevitably is monetary. The concepts are all there. The goodwill among many is there. The question is, how do you do that and make money for the people that need to make money so they support the journey? So we can continue that discussion. And I also suspect both of you have great insights on that topic that I don't have. But I differ slightly in the, let's call it, extremity of your analogy, jug of water, loaf of bread. I actually think what is currently referred to as the healthcare system and health are on the same spectrum. Because, for instance, the times when I've had acute injuries and I've needed the care of an orthopedist, it enabled me to get back to the lifestyle that cultivates my vitality at its origins. And when I've had acute infectious disease, which, by the way, has at times been a byproduct of living a vital life. I'm out in the woods, I have dogs, I ride horses, I'm exposed to ticks. So I've had Lyme several times. I had anaplasmosis, which landed me in the hospital. It was the disease care system which restored me to the vitality that put me back out there where I would once again expose myself to that risk. There's a continuum there. And of course, it's a continuum I've lived pretty richly in all aspects of my career. And as you mentioned, I spent the bulk of my career at Yale and an affiliated hospital, Griffin Hospital in Derby, Connecticut, doing the academic physician's triathlon of teaching, research, and patient care. And in all of those, I appreciated the spectrum of care. So in preventive medicine, so I'm a board certified specialist in preventive medicine. And you mentioned the 19 books. Several of those are multiple editions of a leading textbook in preventive medicine, public health, and the rest that comes after, epidemiology, biostatistics. So in prevention, we talk about levels. A doc named Hugh Level initially established this, the idea that there's primary, secondary, and tertiary prevention. And in fact, you can go back further and talk about primordial prevention, which would be intergenerational. So when you have an influence in prenatal care, when you can affect the health of a mother who's carrying a child, you actually can start to alter the epigenetic settings of that embryo, and you can start to shape taste preferences in utero. So primordial prevention, spanning generations. But basically, primary prevention is preventing bad stuff from happening in the first place. Humpty Dumpty never falls off the wall. Secondary prevention is preventing complications. That would be rapid response, early detection. Maybe you've done things to minimize the extent of injury after falling from the wall. Tertiary prevention would be rehab. so you've done nothing to prevent the fall, or maybe you have and it just failed, but you want to minimize the functional deterioration that results from illness or injury. So when you think about that full spectrum, prevention is everything we do in medicine. A lot of what we do would be tertiary prevention. People have chronic disease, they have diabetes, they have heart disease. We're still intervening to prevent them from dying from it, or going blind from it, or having kidney failure, or needing amputations and so forth. And even when those happen, you could argue you're still somewhere on the spectrum of preventive care, preventing the next calamity. But on the other hand, I agree with you entirely. Just about everything about the modern medical system is reactive, and it's after the bad news, and does very, very little to prevent the bad news from happening in the first place. It doesn't cultivate vitality at its origins. And you could argue that that's because, well, that's really a cultural job more than a clinical job. Do we really need people to have 5, 7, 9 years of postgraduate medical education to tell you to eat more salad, and less ultra processed frankenfood? Do we really need that level of training for people to do something about enabling you to get a walk in every day? Couldn't anybody do that? Couldn't your employer just say, we're going to have a walking break 3 times a day? It's simple. But where it works best, and we should definitely have the conversation about the blue zones more extensively as we continue the conversation, but where it works best in places like the blue zones, where people are beneficiaries of health promoting behaviors, it's delivered via the portal of culture. We know from Mary Poppins, a spoonful of sugar helps the medicine go down. Lord knows the last thing people here need is more spoonsful of sugar. But if we think about the medicine and the spoon, I would argue that lifestyle is the very best of medicine. And the big spoon that can help it go down at the population level is culture, not clinics. And maybe what we need is to conjoin them more effectively and say, how do we put that full spectrum of care together? So we have disease care where we need disease care, but it's better connected to genuine health care, right? So I don't see it as disjointed as you described, jug of water, loaf of bread. I think they're closely related items. And in fact, they interdigitate because the disease care system is at times what allows you to get back to the health care part of the spectrum, as I described for myself. But you're right. We unduly weight disease care, talk about it as if it were healthcare, and consequently invite ourselves both at the individual level, where we become somewhat fatalistic. If stuff happens to me, the disease care system will put me back together. And certainly at the population and system level, to neglect genuine healthcare. We neglect it in clinics. The lifestyle medicine movement is arguably a potential remedy to that. We're trying to change the system, and we neglect it at the level of culture. One thing I definitely want to talk about, Roy, is the obesity pandemic and whether obesity should be considered a disease. Because I think when you live in a disease care system and conflate that with healthcare, it encourages you to pathologize everything, call everything a disease, and develop drugs and surgery to deal with it. When you don't call something a disease, you may think about ways of dealing with it at the level of culture, society, infrastructure, built environment that prevents calamity from happening in the first place. And I'd love to continue the dialogue along those lines.
So David,
Well, go ahead,
yeah.
Webb.
So, we've talked a little bit about this. RFK has come on the scene here, whether he's confirmed or not, and, whether one agrees with many of his positions. He's certainly, he's certainly covered a lot of healthcare or health related topics over the past few months. He has raised public consciousness about the role of the food industry in contributing to the obesity epidemic that you just mentioned. I guess just to start, kind of, what's your view of that contribution that he could potentially make, and what is the connection between the food industry, and the challenges we have with 75% of our population being basically either overweight or obese?
The contribution of the food industry, our food supply at large, and our overall relationship with food is massive. It would be hard to overstate. As you well know, we've talked about this before, and it's largely on purpose and for profit. I refer to it as predatory profiteering, the idea that I'm going to mortgage the future health of your children for the sake of my corporate coffers and just deal with it. And we do. And this has been exposed repeatedly and vividly. And I ask at every opportunity, including here today, where is the outrage? How can a nation of well-intentioned parents and grandparents look at this and not act on it as citizens, as voters, as activists. And what I'm referring to is the exposure of the industry science to engineer food that is, for all intents and purposes, willfully addictive. The first time I encountered this story was in 2005. It was a 4-part expose in the Chicago Tribune, which, by the way, the new owners of the Tribune have expunged from the web. I had a link in a number of my columns over the years referring to this 4-part expose entitled The Oreo, Obesity, and Us. You can still look that up on the internet and you'll find it, and then you'll go to the link and it's a dead link. Very interesting. And it spilled over from late 2005 into early 2006, and it told the tale of large food companies hiring teams of scientists, giving them the best available tech like functional MRI machines, and marching orders to strive for the bliss point, design combinations of flavors and textures that put the human appetite center, which they could image with functional MRI technology, into overdrive. So you actually could see the level of activity in the ventromedial hypothalamus, where the human appetite center is located. And the marching orders were figure out what to do to food to make that thing light up like a Christmas tree. And they did. The 4th entry in this 4-part expose was entitled Where There's Smoke, There May Be Food Research Too. And it pretty much gave us the smoking gun. This was the time of the national class action lawsuit against Big Tobacco, the Big Tobacco settlement. For people younger than we are who need to look this up to know what we're talking about, but state attorneys general had filed a class action lawsuit against Big Tobacco and subpoenaed 3 million pages in documentary evidence. These investigative journalists gained access to that information, that treasure trove, via the Freedom of Information Act. And that's where they found, well, Altria is a holding company that is parent to both Philip Morris, okay, that's the tobacco story, and Kraft. And because these documents were secured under subpoena, basically Kraft had to spill the beans too. They weren't part of the lawsuit, but basically scientists from both sides of the house were working together. So the story was told how Big Tobacco was trying to figure out what to put into cigarettes to get young people hooked. And Big Food was trying to figure out what to do with food to make it impossible to stop eating it until your arm got tired from lifting it to your mouth. So we're talking about a 20-year-old story at this point, retold 10 years later by Pulitzer Prize-winning investigative journalist Michael Moss, who wrote Salt, Sugar, Fat, and Hooked, 2 books on this topic, and who wrote a New York Times Magazine cover story. You could hardly ask for a more prominent placement, entitled, and I quote, The Extraordinary Science of Addictive Junk Food. So this was in 2013, I believe. Again, where is the outrage? So we're being told Big Food is willfully engineering stuff that you can't stop eating in a time when we're wringing our hands routinely about epidemic obesity and type 2 diabetes in adults and children alike. And I hasten to append that when I was doing my medical training, we spoke about juvenile onset diabetes and adult onset diabetes. And the distinction was juvenile onset diabetes was an autoimmune disease that destroyed the insulin producing cells in the islets of Langerhans, the beta cells. And adult onset diabetes was a condition generally of overweight, sedentary, middle-aged adults who developed insulin resistance secondarily to obesity, and whose pancreas eventually pooped out from doing all that extra work, and then their blood sugar rose. And in the time since I was a medical student 100 years ago, we changed the name of those conditions to make it okay that what used to be adult onset diabetes was happening routinely in kids. But we did this as a society. We did this. We did this on our watch. And again, I ask for all the parents and grandparents listening in, where has the outrage been? So the role of Big Food in our travails, in the burden of premature death and chronic disease, is massive and overwhelming. And yes, at the end of the day, I believe in personal responsibility. What I do with my fork is up to me, but the choices I have available, choices I make are up to me. The choices I have are not necessarily up to me. And I don't think we can talk about a reasonable level playing field when highly paid scientists get bonuses for designing foods people can't stop eating no matter how much they want to, and the willpower of your typical soccer mom or or or
I,
dad.
I want to,
It's just not
I want to,
reasonable, and to say nothing of the kids themselves.
You
I
know,
want to build
and the
on what you're
result
saying.
being that
I want to build. Hold on. I want to build on what you're saying, David. There's so much more to add to enrich and further the tobacco analogy. I think it's wonderful that you highlight to our audience that big tobacco and big food are the same people, and have been for at least half a century. And in some cases, big tobacco families and owners have migrated. There's a very famous New York family that has migrated into food and away from tobacco, but they built their fortune on tobacco. The analogy with tobacco is great because we knew as a society that big tobacco was killing us in the 40s and the 50s and the 60s. The first class action lawsuit that was won by anyone was in the 80s. So this was 50 years of fighting big tobacco and losing. And we've been fighting big food and losing for a shorter period of time. So we've got a few decades to go. And why do we lose? We lose for very basic reasons. One, the best argument that these owners present to our society, which we absorb, particularly as Americans. And one of the most interesting questions here is, why do we do worse than others? I'm going to keep coming back to the understanding of healthcare versus health, because we keep conflating things that we do badly in one area with actually things that we do well in other areas. So our cancer survival rates are the highest in the world. Right, our understanding of health is one of the poorest in the world.
Well, I don't know that it's all right. Well, as a society, our understanding, I think the powers that be understand it, they just don't want to do anything about it.
Right.
But
so
just quickly, I'll get out of your way. But I just want to point out the analogy between big food and big tobacco is powerful up to a point. There's a fundamental distinction, and that is we've got to eat. So tobacco is entirely discretionary. It can be a dichotomous variable, yes, no. Sure. Food can't be a yes, no. It's much, much more complicated. And what we've done with the food supply is to some extent an expression of, I suppose you could argue, 2 million years of human evolutionary biology, but minimally 15,000 years of civilization's advance, because the problem humanity always had was securing a stable enough, diverse enough, palatable enough food supply to fuel its aspirations. And we invested a lot of our ingenuity in the direction of more. And up to a point, that was a good thing. Similarly, humanity's problem traditionally has been an excessive demand on our working muscles. And we invested a lot of our ingenuity in the direction of easing that burden by developing technologies, initially engaging domestic animals, beasts of burden, so-called, and then engaging technologies to do the work muscles used to do. So, in the natural world, physical activity was unavoidable and calories were relatively scarce and hard to get. We've devised a modern world where calories are unavoidable and physical activity requires a gym membership and specialized footwear. So we've completely flipped the script. So it's like tobacco up to a point, and then it's different. And those differences are where all the truly great challenges reside.
So David, result being now that 70% of calories consumed are from ultra-processed food. I mean, those are the statistics that I've read. So what can be done here? What do you think, RFK or anybody can do, and how should we approach this problem in a way that that has a chance of working at this point?
Yeah, well, so to try and address what the threads both of you are pulling. So Roy, the analogies with tobacco definitely would suggest that there is a place for regulation. Should it be legal to make food addictive on purpose in an age of pandemic, obesity, and diabetes? And the answer is no. Essentially, you're causing harm. So, you can't willfully put toxins in food. You can't put arsenic in your recipe or mercury in your recipe. These are known human toxins. They do better. You can't willfully put lead in. If these things get in, it's an accident. And there are laws about that because poisoning people is illegal. Well, aren't we just poisoning people over a slightly extended timeline when it doesn't cause acute neuropathy, but it does cause type 2 diabetes and coronary disease? So that's what we're doing. So absolutely, there is a place for regulation here. And Secretary of Health is in the position to talk about regulating the industry, standardizing what is permissible, what's not. We're not going to stop processing food altogether, but there are lines that shouldn't be crossed. I also think, and you know this, Webb, that the single greatest driver of the food supply is the food demand. We've seen this in natural experiments. The one I refer to all the time because it's so salient was the height of interest in the Atkins diet. Because at that time, Atkins introduced his concepts in the 1970s. They didn't really catch on then. He reintroduced them as if new in the 1990s. They did catch on then, and in the early aughts, they really took off for various reasons. And tens of millions of people were going on the Atkins diet. And prior to that, there was nothing labeled low carb in any supermarket in the United States, to the best of my knowledge, or next to nothing anyway. And within weeks, literally weeks, I was spending a lot of time touring supermarkets because of some things I was doing at the time all around the country. And within a matter of weeks, there were several, and then dozens, and then hundreds of low carb products, newly contrived low carb foods to satisfy the public's palate. Now, unfortunately, we'd gone from one boondoggle eating low fat junk food like Snackwell cookies to the next boondoggle eating low carb junk food. And the food industry was only too happy to sort of take many of the same ingredients, mix them
Little
up
repackaging.
formulations, and sell us a new variety of junk food at a high profit margin. So unfortunately, the choice we made was a silly one. But what it did show is if we change what we're willing to buy, the food supply changes what it's selling. And they do it quickly, and they do it without legislation, and they do it without litigation, and they do it without sweeping policy reform. The food demand overrules the food supply. So I think we can do a hell of a lot more to empower individuals to understand the value proposition of eating better. Healthy people have more fun. Eating well, being healthy is not a moral imperative. It's an opportunity to have a better life. We don't tell people that. We should be talking about what health is for. B, some of the world's greatest cuisines are also health promoting and sustainable. So you can love food that loves you back. It's not about a choice between good health and good food. You can put them together. C, if you're used to eating junk food, you may think it tastes good because you've corrupted your taste buds, but they can come out of that junk food induced coma. You can go through taste bud rehab. It doesn't take that long, and you can learn to love the food that loves you back. And D, diet quality measured objectively is the single leading predictor variable of premature death from all causes and total chronic disease risk. And you can know it and you can manage it. And the power actually resides with you in every choice you make when it's time to eat or share food, because this is a power you can pay forward to the people you love, your significant other, your children, your whole household. Unlike, by the way, GLP-1 drugs, which we're going to have to talk about. You're not going to share those with your kids, but eating well, you can. So empowering people to know, what is my diet quality? What are the various ways I could optimize my diet quality? And let me choose among them to find one that is first responsive to my particular health objectives, which may not be like yours. Maybe you want to optimize athletic performance and I want to manage my hypertension. Or maybe I want to manage symptoms of menopause and you want to optimize cognition, or whatever our constellation of priorities may be. Mine may not be the same as yours. And I want to go shopping for the best diet for my particular concerns. And then I want to look at options and say, of those, which looks most appealing? Because I actually do want to like the food that I eat. And what if I'm from some particular culture and I was brought up eating Vietnamese food or Chinese food or Mexican food? Do I have options in that lane? And the answer is yes. We can empower people with this knowledge and then take them to opportunities to convert it into routine practice. And as you know, this is what I do, right? So I left academic medicine after a 30-year run because I had invented a new way to assess diet that was easy, effortless, reliable, all the good stuff. We can do it in
So
60
David,
seconds.
as you get into diet ID, maybe describe a little bit your experience with Nuval and how that related to what you're doing with diet ID now.
So a related effort. So Roy, again, we can come back to the supply side and how this can and should be treated like tobacco. But staying on the demand side for the moment, I am privileged to call many of the world's leading nutrition experts friends and colleagues. And I've broken bread with these people all around the world at conferences and meetings. And we eat better than most people, but you'd expect us to, right? I mean, pilots, they're not necessarily better people than the rest of us, but they know how to fly planes. You learn a skill set and you apply what you know. It's an expertise you have. We're expert in eating well. And I thought, well, okay, so we do better despite all this stuff. I mean, the food supply is not different for us. The Franken foods are still out there. The ultra processed foods are everywhere. The willfully addictive food is out there. But all my friends eat well and are lean and are generally healthy and long lived. You go to lifestyle medicine conferences, you see very little obesity. We have a number of people well into their 80s and 90s still giving lectures and traveling all around the world. It's just
You have this. You have the same effect in longevity conferences. You just can't
right.
tell anyone's age. Person sitting
Yeah,
next to you might be 150.
Yeah, right. So the proof is in the pudding. We actually see the benefits of practicing what we preach. So, at multiple points along the way, I've thought there have to be creative ways to take our knowledge, turn it into algorithms that anybody could use at point of purchase, at point of decision. And so these efforts began with the development of something called the ANKI, the Overall Nutritional Quality Index, which basically said, let's figure out from the scientific literature and a group of experts who do better than the rest of the world, what do we use to inform our decision making when we go shopping? Why do you choose that product and not that product? I mean, there's stuff we know, and we're interpreting information available to us on the package, the ingredient list, the nutrition label. I said, well, let's turn that into algorithms. So we did. We built a 30-page mind-numbing computer programming with multiple dozens of nutrient entries weighted for strength of association between nutrient and health effect, the severity of the health effect, the prevalence of the health effect. Crunched all that, and at the end spit out a number between 1 and 100. The higher the number, the more nutritious the food. And then that saw daylight as a commercial program called Nuval, where we put these numbers in front of 150,000 SKUs in 2,000 supermarkets nationwide, reaching 40 million shoppers a week. And just that one innovation. So the idea was not that broccoli is better for you than chocolate chip cookies. The idea was that there's a better choice when you're shopping for cookies and crackers and bread and dairy and breakfast cereal and salad dressing and pasta sauce. So choices within food categories where you actually might make an either or decision. And what we observed was that the range of scores on this objectified scale of overall nutritional quality was quite massive. You could pick a pasta sauce with a score of 5 or a score of 65, it's just absolutely huge difference. So you're never going to find a pasta sauce with a score like broccoli, but that would be silly. But you can find one that's massively better for you because it has no added sugar as opposed to a lot of added sugar, and it has much less added sodium, and it's actually mostly made from tomatoes. And that's true in every aisle of the supermarket. So what we found was that this was unbelievably empowering. And the results for individuals were quite incredible. I met people who lost 30 pounds, 40 pounds, 50 pounds. In one case, a gentleman I'll never forget because it was so overwhelming. Basically, we were touring, I think it was a Tops supermarket in Tennessee. And this guy basically came up to me when he found out who I was and gave me a hug. Said, I've lost nearly 200 pounds in 18 months, and all I've done is use your system. I've just traded up everything I buy, and I fill up on less food. I'm not hungry all the time. I'm healthier, and 200 pounds. Unbelievable. And that's the only thing we did. We just basically gave people actionable intel at point of purchase. I would love to still be in the business of doing that. As you know, Webb, the story of Nuval is a rise and fall. It was a great system, but arguably too great a system because a lot of the Franken foods in our food supply got a 1. And a lot of the makers of those frankenfoods are very wealthy, powerful companies that didn't like that very much. And ultimately they killed it. And so there are still front of pack label initiatives, but by and large, they're less honest, less fully empowering than Nouvel. Nouvel was too good a truth meter for the food industry to tolerate. The efforts in that direction that are still viable are a little less brutally honest. The public, I think, needs that brutal honesty, but almost anything that points them in the direction of this is a better choice than that is somewhat helpful. And that's another thing that RFK could address. And then, as you know, because I had to live through the decade-long rise and painful fall of this system, I decided if I ever came up with something else significant, I would want to be in control, not just of the science, but of the business side, so I could better navigate the challenges. And basically shifted my attention from individual foods to overall diet, but doing much the same. In both cases, you could think of this like GPS. Nouvel was GPS at the level of individual foods, just an easy system to navigate. What's my best choice in the bread aisle for overall better quality bread? And I want the best bread at the best price that my family will actually like, and the best pasta sauce and the best salad dressing and everything else. We're now doing exactly the same thing at the level of overall diet. Where is my diet now? What would I like my diet to be? What's the divide between here and there? And what are all the things that can help me get there? From information to delivering food directly to your home, lined up specifically against your personal dietary destination. That's what we do at the company I work for now, Tangelo, in the food as medicine space. We can do all of that. We can basically give you the fish, send the perfectly prepared fish to your door while we're teaching you to fish so you can eat well for the rest of your life. There's a lot we can do. And I believe in combining efforts to alter the demand with efforts to change the supply, both because both are potentially impactful, and because ultimately to do anything on the supply side, you need the political capital that comes from the demand side. So we've got to be addressing consumers and engaging them in the reform so they support anything we do on the policy side. Otherwise, we know what happens. It all falls apart because somebody yells nanny state. The government's going to tell me what I'm allowed to have for breakfast, and everything comes to a screeching halt because we burn through our political capital and we get nothing done. And we've spent too many decades mired there.
We've got examples, and tobacco is a great example, alcohol is another. We've got industries that come with large global corporations that have tried to sell as much of their product to as many people as possible. And they're incentivized to do so. And they go to work every day believing in the virtue of their product. You know, those who work in alcohol think that alcohol serves a great purpose. Those who work in tobacco will tell you today that tobacco serves a great purpose. Those who work at McDonald's believe the same thing. So we have examples of industries that play a certain role but have been curtailed substantially, both on the demand side and the supply side. I agree with you, David, fully, that it is very helpful to look at demand versus supply. It is very helpful to understand how they juxtapose with each other. And therefore, education on the demand side is critical. And you have even examples of regulated education that have done great things for our society. I have this debate with my libertarian friends all the time. You know, would you rather food had labels on it or not? And it's not the food industry that advocates for labeling. It's the regulators that advocate for labeling. And yet we all really enjoy knowing how many calories we're consuming. And so we have curtailed tobacco. And every step we took, this was incremental. The libertarians pushed back. What do you mean I can't smoke in public? I'm on a street. Why can't I smoke? What do you mean I can't smoke in my office? Why can't I smoke in my bathroom? In my office bathroom? Yes, other people are using the toilet, the cubicle next to me, but I'm using my own cubicle. So every single regulation comes with a counter argument. This is an infringement on individual rights, and yet we move forward and we've made progress. And in most cases, we adjust as a society.
But maybe maybe
and we
we've
see the
made this
benefits.
harder. Yeah,
Yeah.
but maybe we've made it harder for ourselves with big food than we need to, Roy. And maybe the analogy with tobacco just makes it harder. Because as you say, first of all, it was a long, hard slog, even though tobacco is an entirely discretionary exposure, unlike food. So
Mhm.
when we make the analogy, we invite the pushback, food is not tobacco, I've got to eat. And I don't want to be told what I can eat or should eat. I've got choices to make. I want to be the one making those choices. We immediately run afoul of the libertarian argument, if you will. But I think we sort of make it too easy. I prefer a different analogy when I think about the consequences of our food supply. And that the analogy that I've used routinely, including in an invited commentary back in the day in Nature, one of the premier biomedical journals, is with drowning. Because I don't know that there's a strong libertarian argument against, say, swimming lessons. And I don't think there's a strong libertarian argument against lifeguards. And I doubt there's even a strong libertarian argument against putting fences around pools. It's something in the environment that if you are not personally prepared to deal with it because we've done something to make you prepared, or there isn't some safeguard in place, there's a pretty good chance you could get badly hurt, particularly if you're a kid. It could topple into a pool. If there's no parental vigilance and there are no fences around pools, they're just open bodies of water everywhere, and little kids happen to topple in, they drown. And
I'll
it's
take
got
any, David,
so
I'll take any analogy you have to offer,
so
as
there.
long
I
as,
love.
let me finish the thought, because I'm taking you somewhere. So let me travel with me, my friend.
Okay.
I'll take any analogy you have to offer. Fences around pools, drowning, the analogy that I'm offering of tobacco, as long as our journey takes us from educating the demand side towards regulating the supply side.
Well, that's
And I'll
that's
tell,
the beauty
and I
of
say that,
that's the
and I
beauty
say
of drowning.
that,
Yeah. So
and
that's my point.
I say that fundamentally as a libertarian who emotionally reacts to every fence around every pool. And yet I have been, and by the way, fences around pools, there are some things that America actually becomes a standard bearer ahead of European counterparts, things that it does that are safer than what you see in France. And we have this wonderful experience whenever we travel, where we see other countries not regulating things that we regulate, and we think they're crazy. And they have the exact same experience when they come here, but except they see other things that we don't regulate that they do, and they think we're crazy. And in some cases, the libertarian arguments are valid, and they're always worth listening to. I mean, I can list for you libertarian anti-food regulation arguments. What do we know about diet? What the Surgeon General was telling us 40 years ago, he now recommends the exact opposite 40 years later. The science is always changing. Everyone and individual rights. This is your point about the science used to manufacture the exact right formula. By the way, ketchup, I think, is the best example of all, because ketchup is nothing but chemically processed, and yet we can't seem to gravitate towards organic ketchup. We just find it distasteful because the science is so good with synthesized ketchup that our bodies just will reject healthy ketchup. And the ketchup industry knows this. Heinz knows this, and they love it. The same amount of science has gone into marketing and messaging. And so, we are reminded all the time of our individual rights and our right to have something large, a large meal, our right to have something beautiful. A Big Mac on television is a beautiful product, highly colorful. And so there's lots of science that goes into us not doing the right thing. There's also the issue of who the audience is. Some audience members, you, David, were giving an example of your index and how in some cases it made great sense, and those who are interested in health were making very much even better choices based on that index. But in many cases, the audience is not paying attention. So we are a segmented society. We're a local society. We follow each other into restaurant choices. You go into Taco Bell in your local community and you see other neighbors in Taco Bell. You go into McDonald's or Burger King, you see other of your neighbors in those establishments, and you're reinforcing behavior at the local community level. And each of our communities is different. What they do in Denver, Colorado, or Aspen, they're not doing in certain parts of Indiana or Mississippi. So we have many battles on the demand side, many of which we will lose, because not everyone is interested or focused on food indexes at the same amount, at the same level. Not everyone has the luxury of time, and not everyone feels that they have or actually has the luxury of resources. And for many people, the cheapest product wins, or the easiest to grab at the nearest shelf processed cheese product will win, because cheese, whether it's processed or not, as long as it's melting on my burger, it tastes good, so I'm buying it. So how do we reach those people who are heading straight first into diabetes? And that's where, whether we use a drowning analogy or a tobacco analogy, I firmly believe, as a libertarian, there are places where libertarian arguments just don't work. And if we get to a point where our society's health is irrefutably terrible, we've lost that argument, and we need supply side regulation to come in, maybe incrementally, maybe one step at a time, but the need is almost beyond debate. What are your thoughts?
Yeah, I completely agree that we need to combine demand and supply side reform. And again, I think the drowning analogy is very good, because you could argue that lifeguards and fences and posting that there's a riptide and red flag warnings at the beach, that's all supply side. That's all basically society taking an action. That's all nanny state stuff, right? I mean, the lifeguard's there to protect you. I don't need to be protected. I should protect myself. Nonsense. You can get in a situation in rough surf where you're going to need to be rescued, and you want somebody there who's capable of doing that. So it's an added layer of protection, but it's the supply side. And yet you could argue that knowing how to swim in the first place is demand side, and parental vigilance when young kids are near the water is personal responsibility. We clearly see the role for both. We don't object to any part of that. It's the full spectrum, and we want it all. And again, I've never encountered libertarian arguments against the defenses against drowning that prevail in our society. They make sense. At some point, we can all find common cause on common ground when it comes to common sense. The only problem with it, of course, is it is shockingly uncommon. But other than that, we tend to all embrace it. Say, yeah, common sense. I mean, there's an environmental hazard, and we don't want vulnerable kids exposed to that if we can do something about it. So it's relatively non-controversial. And I think that thinking extends to obesity and diabetes and the other consequences of our interactions with the food supply. So we need to enable people with good choices. And there's essentially a regulatory action that's required to make sure that everybody everywhere in this country has access to good food choices, can differentiate good from bad, can recognize the difference. If what we're putting on food labels is enough for nutrition experts to interpret, but not enough for everybody else to interpret, we got to translate it. That's really all the Anki and Nouvelle were. We translated information we had been trained to process and understand into something that anybody could understand in the time they had. We also want to make it convenient. So the fact that 65 is higher than 5 does not take a lot of intellectual bandwidth. You can figure that out pretty quickly. We wanted to make this at a glance. And we're now doing the same thing at Diet ID with overall diet quality, wanting people to be able to discern that in just seconds. And then we need to think about aligning incentives and disincentives, so essentially leveraging behavioral economics so that this makes sense for both individuals and populations. We think about the SNAP program, for example. 1 in 7, and whenever we hit an economic rough patch, 1 in 6 households in the US gets assistance securing the food they need to avoid overt food insecurity. Unfortunately, it lands them in nutrition insecurity because SNAP dollars help poor people choose poor food to get to poor health, and we then spend greater fortunes through Medicaid to pay the costs of treating all that disease that never needed to develop in the first place. It makes vastly more sense on the supply side, on the regulatory side, to attach behavioral and economic incentives to securing good food for good health and it works for everybody in the system. So basically, poor people get good food and get to good health. That's better. Taxpayers aren't throwing their money away, and the government that's responsible for managing these programs, it doesn't run out of money to keep the programs viable. And these same kinds of approaches work just as well in the private sector. So you could imagine a relationship between a health insurer, a supermarket chain, and the consumer. The consumer's job is to have a loyalty card that says, I'm going to shop at the supermarket, that shows me which are the more nutritious foods, and who does it in a way that is actionable and easy and that I can actually trust. And the health insurer says, well, if you wind up with obesity, type 2 diabetes, hypertension, coronary disease, you're going to cost me a lot more money. I want you to make better food choices. I'm going to provide a financial incentive for you to choose the higher scoring items in the supermarket. And frankly, because I'm going to profit more than the supermarket will from having the system in the store, whatever the cost of deploying it on their real estate will cover that too. Because either way, we save more at the back end. I'm not covering the cost of your frequent hospitalizations and procedures than we're spending at the front end to enable you to make better food choices. The issue, let's circle back to the issue of ketchup.
One thing, so David, that's,
just to say, I just want to quickly finish this thing. So I want to re-emphasize this issue of taste bud rehab. Taste buds are adaptable little fellas. They learn to love the foods they're with. And when they can't be with the foods they used to love, they learn to love new foods they're with. It's a very powerful concept. We can throw around the notion that junk food is willfully addictive, but we need to think about what addiction means. And one of the core elements defining addiction is tolerance, meaning the more you get, the more you need. The reason people love ketchup the way it's currently formulated is they're exposed to those levels of sugar. So you actually taste something that's maybe more sugar than tomato, and it's what you expect ketchup to taste like. Your palate adapts to that and you prefer it. If you go through taste bud rehab, which I did with patients innumerable times over 30 years, it's not that hard. It doesn't take all that long. You can actually turn that preference into an aversion, because the idea of pouring packets of sugar over pasta, for example, or packets of sugar over your hamburger is not intrinsically appealing. And once you resensitize taste buds, that's actually the experience you get. It would be like opening packets of sugar and pouring them on your hamburger or pouring them on your spaghetti. It creates an aversion. But you need people's taste buds in a coma to come out of that coma. And you do that by creative ways, personalized ways of reducing their exposure to sugar. You can do the same thing with salt. You can do the same thing with ultra processed food in general. But the goal is not for the rest of your life, you're going to have to eat ketchup made from tomatoes rather than sugar, even though you don't like it. No, the goal is you're actually going to prefer it, because the only reason you preferred a formulation made mostly of sugar and chemicals is you've been exposed for so long to a formulation made of sugar and chemicals that seemed normal to you, but it's not. And when you taste something that's actually made out of real food and adapt to that, and it takes just a matter of weeks, you will come to prefer it. It's almost inevitable. And it's critically important, because otherwise you can see why people say talk to the hand. You're asking me to choose between liking my health and liking food. And health is a vague concept that plays out over a lifetime. Food is something I interact with intimately every day. Talk to the hand. That's not the choice we're asking people to make. That's crucial. Webb, sorry.
Yeah, so no, not at all. I think the question is, first of all, I think that I agree with, with many things that you said, virtually all of them. Having said that, the question right now is, obviously we've made some progress. You've contributed significantly to the progress that has been made over the past decades. And certainly in terms of, providing information that people need to make better choices, and pushing for, reasonable regulation. But have we reached some kind of inflection point which would make, some of this common sense actually possible? Are we there where people have said, are willing to say, I've had enough of this. It's clear that that the food choices we have, are not acceptable or contributing to poor public health, and we've got to fix this.
One hope I have, Webb, and I don't know whether this is true or not. One hope I have is that we're running out of boondoggles. So we've done all sorts of very silly things in trying to address our relationship with food. We're always looking for scapegoats and silver bullets. So, initially
we just found the latest one in GLP-1, right?
Well, right. We can talk about that. But certainly with regard to the food supply, our initial thinking, once we recognized that we were out of the era when our prevailing public health problem was micronutrient deficiencies and we just needed fortification and supplements to fix everything. Once we were into the realm of dietary excess and burgeoning obesity, our answer to that became just cut fat and eat as many Snackwell cookies as you want. And then, of course, that was a boondoggle. And rather than recognize, well, it's not just one thing and we really need to just eat better food overall, so wholesome food and balanced, sensible assemblies. No, we learned nothing from the follies of history, so we repeated them in a new direction and we just cut carbs. And then we kept doing that, just fixating on a single thing. So maybe it's gluten, maybe it's lectins. The pineapple diet, yeah. I mean, the litany, the parade of silly fad diets is nearly infinite, and it keeps going on. So my hope is, well, maybe we've run out of silly choices, right? We vilified fat. We ate Snackwells, got fatter and sicker. Then we vilified carbs. We ate low carb junk food. We got fatter and sicker. Then we canonized protein and overloaded on protein and basically got fatter and sicker. And if any of these
have the Italians changed their diets in the last 500 years?
Well, unfortunately, the whole world is changing their diet in our direction because human biology is the same all around the world, and any place exposed to the addictive allure of willfully hyper-palatable, ultra-processed junk food succumb. So it's pretty sad, and the blue zones are being degraded, and all the places we would turn to say they've got it right. Unfortunately, you see more and more McDonald's and Coca-Cola and Doritos and the like. So yeah, they probably have. But your point, Roy, is that the places around the world where people have done well with food, enjoying good food and enjoying good health, you're exactly right. They're not waiting for the new fad diet. They're not waiting for what did the morning shows say I should eat this week, right? I mean, they're just eating the way they've been eating for generations.
Yeah. I mean, the Japanese have changed, but they still have 5% obesity versus our 40.
So far, to whatever extent cultural defenses have held, they have defended relationships with food that allow for the joy of good food, but the constraints that come from time-honored cultural practices that emphasize actual food, real food, as opposed to ultra-processed food.
Yeah.
So Webb, one hope is that we've run out of boondoggles, which sort of boxes us in and says the only thing left to do is actually prioritize real food, not too much, mostly plants, to borrow from Michael Pollan, right? Wholesome food, actual food, food identifiable as coming from someplace in the natural world in a balanced, sensible assembly. And the other thing that is arguably hopeful is the level of attention to ultra-processed food. And I think we all owe a debt of gratitude to my colleague and friend Carlos Monteiro at the University of Sao Paulo in Brazil. Carlos and colleagues developed the NOVA classification, which took junk food from the realm of vague description. I can't define it, but I know it when I see it, is pretty much where junk food was, to something that we could objectify on a quantitative scale. So the NOVA classification quantifies the degree of processing and identifies ultra-processed food. It's not perfect because there are some highly processed foods that are probably good options in rarefied food categories. And there are probably some foods that aren't really ultra-processed that might register as if they were just because of the number of ingredients, but all of the ingredients happen to be pretty wholesome. So there are edge cases. But absent those edge cases, what the NOVA classification allows us to do is actually study ultra-processed food because we have an operational definition, which results in studies like those being done by Kevin Hall at the NIH, showing that even if you match the macronutrient distribution and even if you match the foods, ultra processing all by itself leads to extra calories every day, weight gain, and ultimately obesity and the metabolic consequences. So there's a tremendous amount of societal attention to ultra processed foods. And they're a huge part of the food supply. As you mentioned, certainly in kids in the US, about 70% of calories come from ultra processed foods. In their parents, a little lower than that, but still the majority of calories. So that's a shocking statistic in its own right. So even if regulatory action were limited to willfully addictive ultra processed foods, that would make a difference. And we could potentially, with regulatory action on the supply side, give people better choices, and then combine that with actionable information on the demand side so people make better choices and understand the value proposition that this is not a lifelong trade-off between good food and good health. I can have both. I can learn to love food that loves me back. And then I think we're really onto something. So are we at that inflection point? I hope so. Been working toward it for the better part of 40 years. One other thing I can let you know, we talked about class action lawsuits before when we were talking about tobacco and using that as an analogy. There is one in the offing now against the food industry for creating addictive ultra processed food. When I was contacted by an attorney involved in the case, asking if I would be willing to help as an expert, I said, Ben, where have you been all my life? I mean, when I read this expose in the Chicago Tribune 20 years ago, 2005, that this is willful manipulation of a large swath of the food supply to make stuff as addictive as possible, I thought I was waiting then to hear about class action lawsuit. It never happened. It's 20 years later. So that could also add to the tipping point, right? If we have litigation, and we have some officials in government who are inclined to do something about this, and we have a high level of exposure of the topic. Social media does a lot of chattering about ultra processed food. Health professionals are talking a lot about ultra processed food. We have to think about where pharmacotherapy like GLP-1s fit in the mix. So we could talk about that next. And then we run out of boondoggles with diet because we've tried every silly thing. So unless we forget what we've tried and do it again, there is some hope these things could come together. And yeah, maybe we're finally ready to get it right. I think there's cause for hope.
Let me build on that. So David, let's assume that you swap seats with RFK Jr. You're approved. You have absolute control and influence over Health and Human Services. You have the ear of President Trump. You can influence regulation at a federal level. And let's bring that down to a very granular concept. I walk into a supermarket 5 years from now, and I'm a single mother, and I don't have time to make educated decisions about which cheese to buy. And I have a very tight budget. I'm working 2 jobs, and I have 3 kids at home that need to get fed. They're hungry. What's different about my cheese shelf offering 5 years from now versus today, with you being in charge for the next 4 to 5 years?
That mom would know the diet quality of her family without any effort. She would have stumbled into it in the medical system the way she had blood pressure taken. It basically, diet quality is a vital sign. You can't avoid knowing it, and you can't avoid having it compared to what it ought to be and what the value proposition of getting it right would be. So going from here to here means less risk for you, less risk for your children, less risk for your husband, less risk for your whole household, means better health, better energy, better vitality, better performance in school and at work. Everybody has that information and is activated, is basically motivated to care about it. In the supermarket, the better choices are clearly indicated with something that, it's a letter grade system or a numerical system. I favor, the 1 to 100 system. Everybody can count. It does away with concerns about low literacy. It's simple, it's actionable. And her kids in school would be taught about that system. So if there's any risk of her overlooking it, her kids would be tugging at her elbow and saying, Mom, you got to use this. The higher numbers are the better choices. Her health insurer would be incentivizing the higher scoring foods and doing this in a very transparent way. So by buying better quality food, just learning to trade up the numbers, she is saving money at the cash register every time she shops. And that drops into a, whatever we want to call it, a health savings account. That extra money can be used for a wide array of things, But junk food, tobacco, alcohol, stuff that's going to be a direct threat to health is not on the list. And that's just the way it is. But fuel, heating your home, family education, clothing, stuff people need, wide array of stuff. But we know from studies in behavioral economics that if you simply give the carrot, say you can spend the money you save on food on anything else, people buy good food and then spend it to buy more bad food. And you wind up chasing your tail. There's no reason to do things that we know don't work. So all of that would be eliminated. And there would be an opportunity to trade up dietary choices incrementally. So I would go so far as to say supermarkets could include intermediate products in sugar and salt. So essentially we would expose this issue of taste bud rehab, that if you're used to eating that pasta sauce or that ketchup and you want to do better, start with this one. This is the middle of the
That's
road
food
choice.
rehab. I love that concept.
Yeah,
That's awesome.
but we
Yeah.
could enable that with products that help people meet them where they are. We would also have more financial incentives for food as medicine. That's the space I work in now. So when people are finding it really difficult, okay, you're helping me in the supermarket, but I still don't know how to cook and I still don't have time to cook. Well, we can send the food to your home and it can be pre-prepared meals or meal kits where essentially you do the final preparation, but it's put together for you. I think we could reorganize supermarkets to better support the food as medicine movement so that shopping is motivated by meals, eating occasions. So it's not just things spread out all the different aisles, but actually there are assemblies of ingredients. So there's the make a family friendly meal aisle or two where those ingredients are assembled together. You pick one from A and one from B and one from C and one from D and put those together and you have a complete family meal. I think there are whole ways of empowering people to make better use of their time and encourage them to derive the benefits from healthy nutrition. And I think it's basically a systematic overhaul where
Yeah,
we are
same overhaul for fast food restaurants, I imagine.
where yeah, well, all of food service ideally should have the same level of transparency. So we tell the truth about food. We empower people to understand it. We empower people to know what the value proposition is. Healthy people have more fun. We don't tell people what to do, but we tell them why it matters and make sure they understand that. And then we personalize the information. So again, when we take blood pressure in everybody, it doesn't feel like it's an imposition. It doesn't feel like it's something you have to work hard to get done, but it does feel like something you have to react to. So you tell me, well, gee, your blood pressure is 200 over 130. That's really bad. I'm going to be preoccupied because I know that it matters. Everybody knows that it matters. And I don't want to have those lousy numbers. So wait a minute, it's really bad. What should I do is the immediate thing that comes to mind. And the system is there to tell you, well, there are lots of things you can do, including monitoring it again. And let's see what the trend is. And let's make sure you really do have a problem. And if you really have a problem, there are various things you can do about it. When the single leading predictor of premature death and chronic disease is diet quality measured objectively, that should be a vital sign and should function the way blood pressure does. And by the way, we've left out to some extent the medical system. Let's pull them in and say, you can largely address blood pressure with lifestyle factors, but the medical system is there to reinforce that. Say, we've got other things we can do. So yeah, some people are going to need the help of pharmacotherapy, at least to get the party started. So there is a place for GLP-1s and other drugs, whether we're talking about obesity or diabetes or insulin resistance or hypertension or dyslipidemia. I want you to handle this with lifestyle, but that's going to take a while. You're going to have to go through a series of steps to improve your overall diet. And while we're waiting, I don't want your hypertension to be an acute danger for you. So I'm going to put you on medication to treat your blood pressure, but I'm going to be prepared to deprescribe once lifestyle becomes your medicine. There needs to be an interaction between what's happening in schools and supermarkets and society at large and what the medical system is doing. In lifestyle medicine, one of the things we brought to the forefront is the lack of education in deprescription. It's actually, there are docs who are conventionally trained who are somewhat reluctant to modify diet because they're using medication to manage diabetes, and they don't know what to do about the medication if the patient actually gets better. I mean, it's shocking and bizarre, but we're not trained in deep prescription. We're trying to change that. So we need to bring all of these components of the comprehensive system together. So we've got more lifestyle.
Are you more aggressively, David, banning certain ingredients that today exist on inside of our shopping markets, inside of our shelves?
So I guess I didn't fully answer your question.
Dyes,
would that cheese still would that cheese still be available? So I would say, let me step away from the specifics of the question, Roy, and bring up a broader concept, and that's the important neglect in our society of first principles. So I'm going to do a tangent, and then I promise to come back to that cheese product that you asked me about at the beginning of this. So our society basically went bonzo over medicalizing marijuana. All the while, cocaine was legal. I'm talking about medical marijuana initially. So we can talk about generally legalizing marijuana for recreational uses, but I'm talking about medical marijuana. They're a tremendously controversial topic and contentious. And all the while, medical cocaine was already legal. To say nothing, by the way, of drugs that are far more dangerous than either cocaine or cannabis. But how do I know that cocaine was legal all the time? Well, I worked as an ER doc, as many of us do when we're getting our careers launched. And I used it, not personally, but treating patients. A solution of cocaine and cotton swabs are kept in a locked part of every emergency department in the US. And they are the definitive treatment for nasal hemorrhage, epistaxis, we call it. Soak a cotton swab in a cocaine solution and shove it up somebody's nose, and it stops the bleeding so you can see what's going on and what needs to be done. And I did that as an emergency physician. At the time, the initial arguments were burgeoning about medical marijuana and whether we should and whether we shouldn't. Well, that divide, the fact that one far more dangerous drug is already legal just because it is, and a far less dangerous drug is hugely controversial because it didn't happen to already be legal, just shows our failure to ask the first principle question. What is the basis for making something legal for medical use? Now, obviously, it involves risk-benefit trade-offs. It involves consideration of whether it has unique therapeutic applications. It's a discrete set of considerations that could and should be applied every time, which would have easily resulted in the decision that, yes, it's appropriate to have cocaine locked in emergency departments for use in epistaxis because it's highly effective and better than anything else we've got in a potentially otherwise dangerous condition. And obviously, if cannabis has specific medical uses, it should be available for that because it's far less dangerous than drugs that are already on the formulary. And again, we have drugs like Dilaudid and benzodiazepines, far more dangerous than cocaine or marijuana. First principles are absolutely crucial. So if I ran the zoo, and we're talking about regulating the food supply, say, on what basis do we regulate at all? Why is it that we don't let ice cream makers put mercury in their product if it makes ice cream creamier? I'm not saying it does, but imagine it did. And why don't we let people making French fries put arsenic in their French fries if it makes them crispier? Imagine that it does. Would we say that's okay? And if we're not saying that's okay, why are we saying that's not okay? Why can't you put anything in everything? Why? Well, let's figure out together, and let's by all means have some libertarians in the midst, because I don't presume the libertarians want to have to ask whether or not there's mercury in their ice cream. Maybe I'm wrong.
They're not adding mercury to their ice cream, I promise you.
Right, but why? And so the question is, if you're regulating anything, there has to be some fundamental logic underlying that decision, and let's identify it. And then let's extend the use of it to all use cases. And again, I've already made the point early in our conversation, Roy, that the difference between willfully addictive junk food that propagates obesity, diabetes, heart disease, etc., and putting arsenic, mercury, or lead in your food product is simply the timeline. These are human toxins with known and specific harms. And we have to decide whether the basis for regulating something is whether it hurts you immediately or over the span of a few years. Do we really think that toxins that require a more extended timeline should get a pass? Or
this is the discomfort. I would take it a step further. I see the delay effect as being a component, but for me, the primary driver here is the knowledge effect. And so we used to actually put mercury on everything. We used to love mercury, we used to brush our teeth with mercury. But where libertarianism, and this really is a debate, the food debate is actually, I think, debate about libertarianism versus social regulation, group policy, right? Public health. And so the libertarian argument is I'm responsible for myself. End of story in the debate. The problem with that principle, it exists, it has its virtues, but you're only as responsible as you're capable of being. And
Right.
your limitations are your knowledge set. And so every libertarian, no matter how many books they read, no matter how compulsive they are about research, reaches a point where they themselves have not conducted a study on the effects of mercury in ice cream. They just haven't done it.
Right.
Someone else has done that work for you. And so
Right.
at that point of inflection, you have a choice to make. You can either delegate to others to come back to you with their knowledge. It's not your knowledge, it's their knowledge.
Right.
Or you can reject any knowledge other than your own. And so what libertarians do all day long is they delegate to others. They just do it a little less willingly. And so
Agreed.
there we are.
Which is why
in a world where every minute we're getting
we're
smarter. What do we do with
exactly
it?
we're highly interdependent. So I would argue, as Secretary of Health, we're going to invoke first principles. We're going to agree that regulating nothing is perilous and foolhardy, and regulating everything, so the government's telling you what you can have for breakfast, is intrusive and wrong.
Or when
And
to
the
drop
basis
it,
for
right? This is
deciding
the
where
thing.
to draw the line has to be rooted in logic and common sense and principles that we apply consistently, and that we can, if not universally endorse, at least largely as a society, say that makes fundamental sense. So again, are dangerous drugs routinely used in medicine because their potential benefit outweighs their potential harm when experts in their use are responsible? And the answer is yes. Most of the modern pharmacopoeia has major potential harms attached to it. And the approval of new drugs then should be predicated on whether they have specific use cases, unique value, and under select circumstances, a favorable risk-benefit ratio. These are fundamental principles that can be applied every time. We can extend that exact same thinking to the cheese product you asked me about. Will it be on a supermarket shelf 5 years from now? And the answer should not be relevant to just that one product, but fundamental principles about, is that a food that's as safe as it can be made, that has not been
You're going to make it better.
that has not been willfully manipulated
Yeah.
to induce harm for the sake of corporate profit. We don't oppose corporate profit, but we're not willing to tolerate intentional harm to public health in order to fatten corporate coffers. No, public health needs to be protected, and companies need to thrive in the economy. Those two things have to happen in a symbiotic way. We're not willing to trade one off against the other. That doesn't mean everything needs to be optimal for health. There will be an array of food choices because, after all, even the least healthful product in the context of an overall healthful diet is going to do minimal, if any, harm. It's the overall pattern. But we need to enable people to make good choices by offering them more good choices. And that specific cheese product, if it has been manipulated to be a cheese product as opposed to a cheese, which would be considered real food, a fermented dairy product with, obviously some degree of processing, but it's identifiable as a food. We know where it came from in its natural origins.
It's a cheese, not a plastic.
If it's been manipulated beyond that in ways to make it more addictive, more hypopalatable, and only that, then it's over the line. So I wouldn't be prepared today to say exactly where we draw the line. I would convene a diverse group of experts. We would define the line, we would socialize the line, and then we would use that line to say which foods are over the line, and you have a certain amount of time to decommission these products. We'll allow the supply side, what they need, so that this is not unduly brutal to them. But 5 years from now, a product that is a willfully addictive ultra processed food should be gone from the shelf because it's toxic. We know it's toxic. We have enough evidence to say it's toxic. There will be more evidence if we just keep studying it, but I would invoke the precautionary principle. You're asking me to be Secretary of Health, so I'm a leading official defending public health principles. In public health, we honor the precautionary principle. I think there's danger over there. We don't have definitive proof yet. And the only way we're going to have definitive proof is to send people over there and watch them get harmed. I'm not going to do that. I'm going to say that risks to public health are guilty until proven innocent. Unlike people in the court of law, I'm going to steer people over here. And we're going to assume there's danger where there looks to be danger. Where we see smoke, we're going to assume fire. And then we will have appropriately qualified experts go over there and look carefully in a safe manner to determine if we're right. And if we get the all clear, we can move back in that direction. But until we get the all clear, I'm taking everybody this way. And I think that's how we should be treating ultra processed food. I say this, by the way, because the work of the Dietary Guidelines Advisory Committee for 2025 was just completed. And they were under strict orders to use randomized controlled trials to adjudicate the harms of ultra processed food. And they reached the conclusion that they couldn't really reach a conclusion. They lacked the bounty of evidence at this point to say people should avoid ultra processed food in general. Maybe not all the time, and I can think of edge cases myself, but in general. But I think the standard of evidence there should have been absence of evidence is not evidence of absence. We do see smoke, we just haven't verified the fire. We're going to take people in this direction while we have experts go in to verify the fire. But it sure looks like there's one. That's where I am with ultra processed food. So I would have argued for that. The precautionary principle makes sense.
I think it's a wonderful answer. And I think, Webb, to your question, are we at an inflection point? I would say irrefutably, unequivocally, yes. And the reason why we're at an inflection point is not because we're smarter, because the truth is we're smarter stochastically. Every 5 seconds, there's another study, there's another shared data point. ChatGPT informs another big swath of society. We get smarter all the time as a populace. We don't go through inflection points all the time. What's different about now is the question. And the reason why I'm very confident that we are at an inflection point is we as a population today, and I don't think this will last because this thing has been going on cyclically forever, but today in the cycle, we are skeptical and distrusting of everything and everyone. We don't trust our institutions. We don't trust our CEOs. We don't trust our large companies. We don't trust our brands. We don't trust our representatives. We don't trust anything. And that is both wonderful and terrifying. There are great things that will come from that. Like, I reject the entire food industry. It's all built wrong. Let's rebuild it. Wonderful. We need to. There are terrible things that come from that. I reject all science. It doesn't exist. Yes, it does. And so we are in an extreme period in our evolution where we are rewriting, redoing. There are great things that will come from that. There are terrible things that will come from that. And in fact, the more good things that come from it, the more trusting we will become. And we'll enter a new period where brands mean something, and authority means something, and elected officials mean something, and institutions like the World Health Organization will mean something, and the UN will mean something. We will come back to that period. And then circumstances will change, and those institutions will be out of step with reality, and we will become distrusting again. So that's my view on where we are right now. It feels irrefutably like a point of inflection.
So Roy, interesting. I mean, I would say what you just described is a point of disequilibrium. I think Webb's inflection point question, is more about specifically sort of intentional, directed movement. Have we reached a point where we will make a productive decision? You described a point of disequilibrium, but I would argue we're not necessarily smarter because of more information. Just quickly, Webb, before I toss to you, but as a clinician for many years, my career began in the pre-internet age, and back then people knew what they didn't know, and they'd come to the doctor and say, "Tell me what to do," and some would feel differently and say, I I want to be in charge, but I came to see you, so I want to know what you think, and then I'm going to decide what to do. I told all of my patients, you're the boss. It's my job to empower you with an understanding and options as best I can based on my training, and then defer to your decision making. But my patients were relatively humble because they didn't have access to all the world's information. With the advent of the internet and increasing exposure to it over the years, I watched that script change. Everybody knew everything, and most of it was wrong. And the effort to drain away the misguided interpretations was massively greater. What is it, Bartolini's law or something? There's some law, just the effort required to disabuse people from the bullshit they believe is just massively greater than the effort required to gain access to the misinformation in the first place. Something to that effect. Anyway, that's absolutely true. So I don't know. I don't know that we're smarter.
Brandolini's law.
Brandolini, that's it.
As the bullshit asymmetry principle.
Yes, perfect. That's what I mean. And
it's
true.
The effort of debunking misinformation is in comparison to the relative ease of creating it in the first place.
Exactly. So it's certainly true in clinical medicine, and you're right, we're bombarded with all this information, so people don't trust the system. But the problem is when there is distrust, and then there are essentially proposals for remedies. In a large fractious society, there are diverse proposals for remedies. And if nobody trusts anybody, then nobody creates the critical mass of inertia and momentum to prevail.
I'm creating a new law, Bejarano law. The level of distrust in a society is directly proportional to the level of data and information in a society.
So then the more information is not reliably empowering, right? It may actually be fractionating and may create something of an impasse because there isn't enough collective trust for any given approach for that to gain momentum. And then what inevitably happens is the approaches that prevail are those that are rooted in the greatest wealth and power. And the greatest wealth and power inevitably at any given time is affiliated with the status quo, because wealth and power in a given system has to do with people who are benefiting from the system as it is. And so then there's the question,
Right.
Are we really at an inflection point? I hope so. I'm less sure of it than you are.
Well, what do you think?
I think, everything you said is true until the whole thing becomes unaffordable. And I think we're at that point in terms of the system as a whole. So, you've got a system where
collapse.
75% of citizens are overweight or obese, 30% have at least one chronic condition, 60% have more than one chronic condition, more than 100 million people have diabetes, more than 100 million people have heart disease, and we have an aging population. And we talk about the inadequacies of our healthcare system, and that's a whole nother debate structurally. But the reality is, if you have an underlying very sick population that's also aging, that piece of it alone is going to make the system unsustainable. And if you believe that, the diet quality, is an underlying cause, it has to be addressed. And I think that we're getting to that point, whether, we're actually there or not, and whether RFK, gets confirmed, can really bring this to the forefront. If he did, that would be a gift. And it would cause us to debate, what the solution is, but at least we would be having that debate, and we haven't had it enough, and we need to have it.
Yeah,
you've been pushing for that for years,
right?
That's what we need. We need it to be part of the public consciousness, and we need some urgency behind finding a solution. And as you say, it's not one extreme or another. It's first principles and finding where on that line we want to land. But it needs to be done.
Right. Yeah, and I agree with you. Webb, you could argue that the most compelling aspect of the inflection point argument is we are facing potential collapse. Health systems that can't continue to function because they're too stressed. And our society probably is not willing to tolerate the inability to get emergency care. And ultimately that's what it comes to, right? So, across all levels of society, there has to be an intolerance. So when there's lack of trust and there's information overload and there's more misinformation than reliable, actionable intelligence, the question becomes, what would induce this vociferous society to take collective action and turn this constellation of stresses into an inflection point and intentional movement toward an alternative? And the only thing that really comes to mind is lack of choice. And what defines lack of choice is consequences that we're not willing to tolerate. Because otherwise, there's always choice. You could just do nothing. You just say, okay, the system collapses, it collapses. But what that means is someone you love needs emergency care for an acute crisis they can't get because we shifted all of the burden that ought to have been health care to the disease care system. We basically compressed the spectrum, said, you guys just deal with all of it. The stress was too great, the system collapsed, and now the actual disease care can't get the attention it needs. And what that means is somebody you care about is going to die in pain while you watch, and the system won't be there to deal with it. And if that's something we're not willing to tolerate, then the remedy doesn't reside trying to pack more resources into this narrow part of the spectrum. It resides saying, over here, we can't be this sick to begin with. So I agree with you that in some sense, there's hope in our despair.
Yeah.
The fact that we can't go any further in the direction of misguided thinking without causing the system to collapse in ways our society simply will not tolerate. The question then becomes, and we could ask the same question, by the way, about climate and the environment. Will we recognize it before or after the true calamity? Before or after the full expression of the consequences, right? So, how far will we go in the direction of closing hospitals that just can, they're not economically viable, they can no longer function because essentially we're asking them to step up and deal with the neglect of healthcare. We're asking disease care to deal with the neglect of healthcare, and they can't take the stress. How far will we go in that direction? Is the inflection point before things get desperately horrible or after? And I don't know. And I have some colleagues in the environmental side. And I believe that health is health. And we have some hope of being healthy, vital people on a healthy, vital planet, or we have no hope of being healthy, vital people. So planetary health, public health, they go together. I have some colleagues on the environmental side who are also having this conversation about inflection points and hope. And some say it's going to get really, really bad before it gets better, because that's what it's going to take.
On that wonderful note, I have one last question for you. I really appreciate your time, David. So last question, 10 years from now, not 5, but 10, we have solved the food issues in America. We've had the right leadership. We've moved away from factory food, processed food, into real food. We have solved the obesity issue in America. And now we're looking at the next crisis. And you're playing the same role. You're raising your hand, Cassandra-esque. Are we paying attention over here? So let me give you some candidates for the next culprit that's driving the most amount of chronic illness in America. And maybe I missed one, but my question is, what are you most concerned about beyond food and exercise? So here are some culprits. The candidates: microplastics, the Texas, maybe it's Texas and Oklahoma at this point, floating plastic island in the Pacific Ocean. COVID, ignore the vaccine, just COVID and the realities of long COVID, a lab engineered disease that we've all got multiple times. I can't remember the last time we all got a lab engineered disease. This is a new paradigm that we're in. Vaccines, and this is part of my concern with RFK Jr., is we very rarely as a society, and every nation suffers from this, have a clean and honest debate about anything. Because tactic number one, when you're counter debating, and I used to be a debater, is pollute the topic with misinformation and misdirection. So RFK Jr. wants to have a debate about food. Everyone's going to want to have a debate with him about vaccines. So throw vaccines into the mix. GLP-1. It looks like we're on our way to a GLP-1 world where everyone and their grandmother is on it for any reason imaginable. The miracle drug. Do we believe in miracles? What is the culprit that we are ignoring right now that is percolating? Painkillers. We went through an Oxycontin, Sackler family, Purdue-driven pandemic of its own. We seem to be coming towards the other side of that, where we've learned our lesson. Science has caught up to reality and is directing us in the right path. What is the sleeping giant that keeps you up at night beyond food and exercise?
So there are quite a few things on your list that concern me and some things that aren't, but you've asked me to pick the number one thing. So again, I'm in a position of power. It's 10 years from now. We've solved the food problem, which means presumably sustainable, wholesome, health promoting food, accessible to all. We've done away with hunger and all that. That's a tall order in a decade, but yay for us, we did that. Assuming that we did that without tackling the issue of misinformation, disinformation, and malinformation, then those are the singular threat to the best destiny of humankind. And that's where our attention needs to be directed, because they are responsible for the impasses across the full expanse of issues you raised. If people had access to reliable, trustworthy information about when vaccines are a good idea and when the risks could potentially outweigh the benefits, we would reach sensible decisions about vaccine uptake. If we had access to reliable information about the harms of plastics and the availability of alternatives, we would have the political will to do something about that problem, and so on across the full expanse of that list. The single greatest threat to the effective application of Homo sapien ingenuity to the best potential future we can devise is our failure to come together in common cause on common ground in pursuit of things informed by common sense. And that's because our sense of how things are is not held in common. It's contaminated by the massive proliferation of dissenting views and the ability to disseminate misinformation and malinformation, where information is willfully manipulated to do harm, to distort, to deceive. And so, frankly, I see that as the single greatest impediment we face. I think our efforts could be directed there. There are other things of great importance: loneliness, stress, essentially the incompatibilities of basic human adaptation to modern living. But even there is a solace in perceiving a connection to other humans, and the ability to have a common understanding, I think, is substantially underrated in terms of its influence on our fundamental mental health. Feeling like I'm part of something bigger than myself, where the things, the views that I perceive around me resonate and make sense, and I'm proud to be a part of it. That it's effectively a remedy for loneliness, because you feel the connection. We are connected in ways that make us feel isolated. Essentially, the social media experience is incredibly isolating. So we've gotten connection wrong. Single greatest threat deserving our attention, and obviously AI is part of this conversation, because the greatest.
And we're leaving violence and conflict aside, because that's always
well, but actually the echo chambers that are largely fueled by distortions of information are responsible for us failing to recognize that we're all more alike than different, that we all care about the same things, that the way we feel love and fear and anxiety are all shared, and that none of us is truly alienated from any of the others, that the basic bonds of humanity are fundamental and profound and can allow us to connect to one another. But we contaminate that with misinformation, and we contaminate that with distortion, and we drive wedges in. That's what deserves the focus, because I think we solve the problem of misinformation and distortion we create a world where signal reliably rises above noise, and then we can follow the signals where they lead. And we can do that with the strength that comes of unity. Absent that, we're capable only of our own destruction.
Noise. You're concerned about noise, it sounds like.
I'm concerned about noise and the inaudibility of signals, and our failure even to to generate them, but even to agree what they are. So it's more than just the noise, but yes, I think we're weighted down by fractionating noise.
Yeah, well said.
David, I want to thank you for your time. It was a very interesting conversation. I learned a lot. And Webb, I want to thank you for your time as well, and looking forward to staying in touch. Thank you, Dr.
Yeah.
Katz.
Pleasure, gentlemen. Thank you so much.
Yeah. Take care.